Today, we will be talking with the Community Outreach Health and Recovery Unit, also known as the City of Somerville's COHR unit. We will be recording this meeting for those who are unable to attend this evening. The goal of the Public Safety for All informational series is to raise awareness about the current public safety efforts in the City of Somerville and the individuals who help to provide these services in advance of the findings collected from the Public Safety for All survey and focus groups. As we all know, we have amazing leaders in our public safety efforts for the City of Somerville, and we are honored and very excited to continue to introduce the City of Somerville constituents to our amazing leaders who help in these efforts every single day. Before I introduce our panelists for tonight, I would like to provide a few community norms to help guide this meeting. As you know, we will offer an opportunity for constituents to ask their own questions to our COHR unit leaders. Number one, please speak your truth and use I statements. Number two, respect everyone's opinion. Number three, listen with an open heart and mind. And finally, number four, expect and accept non-closure. When we open the floor for questions and comments, please use the Q&A feature to ask a question of the panelists. I will recognize your Q&A feature, and we will definitely monitor the questions received and pose them to our panelists. Tonight, our four panelists are members from the Community Outreach Health and Recovery Unit, again, also referred to as COHR. COHR is Somerville Police Department's in-house program and was created to provide assistance with assessment, referral, alternative to arrest, as well as pre and post adjudication planning for individuals impacted by behavioral health. Tonight, we are honored to be joined by Patty Contente, Director of COHR, Cheryl Delafano, Jail Diversion Coordinator for COHR, Jen Korn, Co-Director of the MB-CIT TTAC, and Sabrina Ozit, Coordinator of Law Enforcement Partnerships. The Community Outreach Unit has three primary focuses, which is community outreach, training for community and law enforcement, and diversion from criminal justice system. It is supported by 2 grants from the Department of Mental Health, as well as city funding. They work with cases that are non-criminal as well as court-involved cases, and their goal is to develop diversion plans that will support behavioral change, hold the individual accountable based on their capacity, and assist them in accessing services that will reduce recidivism. They also host quarterly stakeholder meetings with Somerville providers, of which RSJ department attends, to increase cross-discipline collaboration regarding strategies to better serve and address residents' needs. Their goal is to provide intervention to address ongoing risk factors and work with community health providers to facilitate access to mental health and addiction supports. I would like to now open the floor to our panelists, as they have very intentionally created some visuals to speak with us about their roles and how they support the city. So could you please share with us what is COHR's program's role in public safety in Somerville? How many people do you serve per year, and how can the community access your services?
Sure. Thank you so much, Denise, for that introduction and overview. We just wanted to give you an idea of kind of our staffing. And as Denise mentioned, we were really set up as, kind of an integrated public health and public safety model. When I first started working with the police department, it became very clear to me. I'd actually been the clinical youth specialist at the health department for the city for about 4 or 5 years before I started working with the police department. And in that role at that time, that was 2008, it was hard to connect with people in the community. And then we started, through a stakeholder meeting at that time, we started to think about, kind of the concerns around people getting, kind of involved in the criminal justice system, looking at the data. People are with mental illness are 5 times overrepresented in the criminal justice system as compared to the general public. So we started looking at the calls for service that the police were responding to, and we saw opportunities to really connect with those populations as an effective intervention point. And so our staffing is myself, I'm the director, as Denise mentioned. Cheryl is our clinical coordinator for jail diversion, but she also works, generally on cases. Cheryl's a licensed drug and alcohol counselor. Jen and I are licensed clinical social workers. And then we have support staff. Sabrina has a research background. She's going to be speaking to the numbers of populations that we serve. And she primarily works on the Metro Boston Crisis Intervention Team Training and Technical Assistance Center, which is what that acronym stands for. And then there's a project assistant position, which is currently open right now. So we're low bar access. We can go to the next slide. And, as Denise mentioned, we have a number of different programs, community outreach and direct services, primary or low bar access, which means, people often ask, how do I, make a referral to you? We say, just call us, walk in. That's the luxury of being within the police department. It's a agency that's open 24/7, 7 days a week. We are not here 24/7. But if someone comes in and is inquiring about connecting to services or connecting to COHR, officers are absolutely able to take a message, to get that to us, and we will follow up. So, we really will our model is responsiveness. So we really try to meet people where they're at. As Denise said, we address sometimes folks who are criminally involved with the criminal justice system or have criminal complaints. A lot of people are more at risk, I would say, right? Their behaviors are getting to a point where there might be complaints, public disturbances, things like that, where it makes sense for us to try to intervene. Cheryl, I'm going to turn it over to Cheryl to talk a little bit more about what that daily outreach looks like.
Okay, hi, how are you? So as far as the outreach, a lot of times we'll have clients or people walk into the police department anytime during the day, and they usually go to the main desk, and then they refer those clients over to us. And they're people that walk into the police department that are having some type of a crisis. Sometimes someone will walk in because they're looking for a detox. Someone will walk in because they're having issues, such as I just don't feel right, or something's going on in my house that I really need to speak to someone about. And it's amazing. They'll come in and, it's very informal. They'll sit down and just sit back and just ask them what's going on. And surprisingly enough, they open up and they seem very comfortable. And a lot of times if they have a legal question, I will call over to the one of the officers, and they'll come in and they'll speak very quietly. We'll sit down, we'll discuss. I'll ask, what's bothering you? What other type of legal questions do you have? And they'll ask the officer, and when their questions are over legally, then the officer will leave, and then we'll continue. So the outreach consists of me getting some information from them, living conditions, what's going on, how long it's been going on, and do they have any services in place? If not, I'll usually ask them, what's on your mind? What do you want to see happen? And from that point on, a relationship has been started, a professional and really concerning relationship.
When you say, do they have any services in place? Can you just explain a little bit to us what that means?
Okay, so if someone comes in, let's say they're filled with anxiety because of stuff that's going on in their house, right? Or at work, or just in their life. Have you talked to anybody? Do you have a doctor, a primary care doctor in place? So have you talked to any, to a therapist or a social worker before coming into the department? Most of the time, the answers are no. And then they'll ask, well, would you need help? Would you like help in doing that? And that's how it starts.
Thank you.
No, a lot of times the answer is yes, though, too. So
Mhm.
we work with a lot of folks who are, we're funded, as Denise mentioned, through the Department of Mental Health. So we do have interactions with folks who are receiving those services. And so oftentimes what we've discovered in our process is that oftentimes people do have a psychiatrist, do have case managers, but because of a lot of different variables in terms of stressors, other life stressors, finances, education, they may not really fully utilize those services. And I always say to people, those doctors, therapists, they work for you. So, what do you want, right? As Cheryl was saying, what are your goals? What would you like to see come of this? And that's not always easy to do in that healthcare setting. As you can imagine, I think all of us have been to the doctors, and I always use the analogy, I go to the doctors for my annual checkup and they're like, okay, Patty, how you doing? I know there's only 15 minutes. Been sitting in the room for a half an hour. So how you doing, Patty? How are things? Great. They're good. Everybody, we want to be good in those moments. And then as soon as I leave, it's like, I wanted to ask about this pain I've been having, and I just forgot it. So again, it's kind of, really kind of having that. And people will call us 2-3 times a week because there is no scheduled time for a crisis, right? So it's hard work. It's hard work, trying to figure out a lot of the basic life needs, as well as this dealing with the stress and anxiety. And so we try to, kind of just touch base, be available. We don't have endless amounts of times, but, people are very appreciative and, can understand, okay, I have a couple of minutes now. Can you, what else can we do to put in place that's going to get you through or support you?
I wanted to add that we, for our constituents, that we put the contact information for COHR and Metro Boston CIT TTAC. And Patty, you mentioned it's a lot of work, and I know it's complex work as well, and you are a small staff, and I just want people to have an idea of how hard you guys work. Could you give us an idea of how many people you serve per year?
Sure. Yeah, I'll turn it over to Sabrina because she is our, kind of data whiz. And if we jump a couple of slides forward, I think there's a graph there, and Sabrina, you can fill in the details.
Yes. Hi, everybody. I'm Sabrina. And so everybody's been referring to how complex the cases are, and 2 or 3 calls a week, but it's really like 2 or 3 calls a day. And these are just numbers to put into, to give you an idea of how active we are here in the unit and how flexible we are, because it really is blue bar access. And so in 2020, when everyone's kind of adjusting to COVID, we still were partial in person. And so we saw about like 1,800, we had about 1,800 interactions. And that really is just reflective of, the phone calls get complex. So you call a provider and then they're not able to make the appointment. So you have to call again, and it's about being put on hold. And with insurance, you have to reapply every year. And so clients are calling because things get complicated. You come in for one thing, but you realize you need B, C, D, E, F, G, H. And so this graph really just illustrates our numbers and the interactions that we're having from year to year. So in FY21, we had 2,800 interactions. FY22 is roughly the same, 24. And in FY23, the numbers are still kind of getting calculated, but we're also at 2,000 interactions. And so, and just to give you an idea of how many people we're working with, it's not 2,000, but in 21, it was 217 people, just unique individuals that are coming into the office, often unscheduled, often needing us to coordinate something, get them into detox or speak to a provider, or just whatever they need. We meet people where they are. We've helped make resumes, we've helped fill out job applications. And so in FY23, we're already at 383 unique individuals. And so the needs really are getting more complicated. And because we're low bar access, because we don't ask for insurance, they're able to come in multiple times a day. And we are able to spend that hour, sometimes 30 minutes it takes to be with them, and then they come back, right? And so we're able to have that flexibility. There's often a client who's like, I have to go to work and then I'll come back, or I have to go make dinner and then I'll come back. And so it speaks to our ability to meet people where they are, to address those complicated needs. I don't know if anyone else anything else to say. And it also speaks to just being here in the department, because with COVID, the police department was open. And so we were here the whole time. And so people know in an emergency, you go to the police department. And so oftentimes there are people here in the lobby or people here walking in, because we are still very much in person, and we have that flexibility of not needing to, we love appointments, but we also appreciate when people just come in, and Cheryl's office is right across from the lobby. And so we're able to meet them where they are in the moment, and kind of have that flexibility. And we're also just responding to reports. And so when we're not here on the weekends or after 5 o'clock, the officers know we have a physical presence here, and they know we'll respond. And so they'll write reports, and we'll just give them a phone call. And so some of that is just following up on, you've had a crisis, acknowledging that, what can we do for you today? And just breaking it down with them, and just acknowledging, you know, you're not in trouble. We're really here just interacting with, like Cheryl said, what can we do for you? What is your need today, right now in this moment? And so the increasing number of individuals we're working with, and just the high constant meetings, just speaks to the complex nature of the work and just life.
Thank you, Sabrina. Before we go into constituent questions, I had one question. Clearly, the community is aware that COHR exists, and those who get to experience the services that you provide, it seems to me, have a good experience because they do return. So it's a safe space. How do you inform the community that they can have access to your services?
Yeah, so because our primary focus was on being a diversion point from the criminal justice system, so our primary source of referrals are the officers. As Sabrina mentioned, we have we adopted the records management system here at the police department, so that when officers respond, when a call for service comes in and the officers respond, if they learn on scene that there was some component of behavioral health that influenced the call for service, so that could be mental illness, developmental disorders, just overall stress factors, living environments, unsafe living environments, the officers answer a report question, yes for substance misuse or yes for mental health. And when they do that, those reports, we're able to search the database, the entire police database, to look for calls for service that have those components. It's important to understand that we're not following up, or we're not searching for calls that are labeled psych emergency, or even suicide or suicide attempt. Because we do have a small staff, as Denise mentioned, and because our intention in setting up this program was to really have that diversion impact, we figured that those calls, a psych emergency, that really means that someone is going to the hospital. Someone's, a provider has, issued a section, and someone's going to go to the hospital, and they're going to get connected there to a healthcare provider. And so the calls that we're following up on are more typical of, unwanted, a public disturbance, an assault, a theft under, 12,000, larceny, whatever, family disturbance. And so those are the calls for service where we find that folks are, their idea is that they don't see themselves, and they may not have a mental health diagnosis, but we all have mental health, and some days are better than others. And so what are those, how can we kind of build capacity, increase understanding of how important it is to manage our stressors, to take care of our mental health, and ways in which we can do that both formally and informally. So our primary referral source are officers, and actually recently the officers are taking our cards and handing them out on calls for service. So it's like, oh, officer so-and-so said to call, which is great, so that's a primary source. And then in addition to that, Denise, as you mentioned, we have quarterly stakeholder meetings. We partner with a number of providers, you know, from a lot of city departments, your department, the libraries, the Council on Aging, in addition to Somerville, Cambridge Elder Services, Cambridge Health Alliance, you know, kind of Cambridge, the Somerville Homeless Coalition, the First Step Outreach Program, BCOE. So at these stakeholder meetings, people come together, we share trends, concerns, and we also collaborate on cases. We get a lot of referrals from the Office of Housing Stability because folks, you know, are primarily in, you know, a primary need is housing, but maybe because of life circumstances, you know, kind of capacity, they need a little extra support to access those services and, you know, support in going through the processes. They're not easy, going to court, things like that. So it's really kind of what I love about Somerville is it's always been this grassroots organization that is founded in, you know, a family where their safety plan for a family or adolescent is if their behaviors are to a point where the family doesn't feel like it's safe for them to manage, then it's part of their safety plan to call public safety. So we've done, you know, kind of meetings, and we've had officers go to families' home just to do an introduction. You know, here's an officer. If they are called to your house, this is why they're here. No one's in trouble. We're here to support you. So really trying to reduce the stressors if a family needs to that support to keep everyone safe and those kinds of things. So that's some of the ways that we get the word out about.
Thank you,
COHR.
Patty. And I should say, you mentioned collaboration. I should say that COHR is also going to be part of the Civilian Oversight Task Force and the Public Safety for All Task Force. And so we knowing the limitations of capacity and staffing that you have, we are very appreciative and value the wisdom that you will be bringing to the table for both task forces from your department. So could you speak to some of the challenges that your program has encountered and why? One of our constituents has asked that question, and I promised to move forward into constituents' questionings.
Yeah. Jen, I want to kind of turn over to Jen. We work as a team. And so Jen, I know Jen is the co-director, but she also does a lot of the outreach as well. So Jen, do you want to start off with some of the challenges?
Sure, yeah. So I'm Jen Korn. I'm a social worker, like Patty said, and work with the core team as well as the training side of things. I think recently, just with COVID, we've just seen so much more distress in the community, especially, you know, we were mostly in person for most of the, 2020, 2021, when there were a lot of providers that weren't open, at least, meeting with people in person and having doors open to the community. So we just saw a lot of distress, and we're seeing the ramifications, the ripple effects, continuing. Long wait lists. I know there's a shortage of clinicians, nationwide. A lot of people are preferring to be virtual. They don't want to work in person. There's just, the pros and cons to all of that. So we're seeing, I think there's someone that I tried to refer, it was like 3 months to get an intake and then 6 months to see someone. So that's, 9 months. And we are primarily not, long-term care, but we do see people for as long as sort of needed. Sometimes that's, in bits and pieces. They might come back to us after a year or so if they've, had a relapse or something like that. But we are working with people longer to get them in a place where they're able to receive the care when the care is ready. It's kind of like both things have to happen, not simultaneously, but the person still has to be ready when 9 months from now there's a spot for them, and then it has to be a good fit for them, and the commute and the insurance and the copay. So there's all these barriers, and so I just think that we're seeing more of the barriers, and we're seeing more distress, and we're just trying to help people navigate that system and navigate life as things are reopening. And it's been a big challenge. And I was going to say earlier, just back to the outreach piece, that sometimes what we do when we talked about, like, if people have providers or don't have providers, some people have a lot of different providers that aren't necessarily communicating. We always have people, if they have providers, sign releases. Sometimes our role is trying to bring people to the table to have conversations to help everyone get on the same page for treatment, because we'll hear from the client, I told the doctor this, and then the psychiatrist did this, and it's hard to navigate those systems, and for people to advocate, it's hard for anyone to advocate. So really accompanying them on that process, and I feel like bringing people together to the table to have those discussions in the best interest of the client is something that we find ourselves doing when there's all this siloed care. And I do think that's gotten more challenging with COVID as well.
We have another question from, and we can continue on the challenges question as well if someone else wanted to chime in, because I know that your roles and responsibilities within the department differ. So we can definitely continue in that journey of explaining the challenges. But for the Metro Boston Crisis Intervention Team, we have a question from our constituents asking what are some of the changing dynamics that are contributing to heightened demand for services. And I know COVID was one of the things just mentioned. So I want to add that question to the what have been your challenges in the programming.
Yeah. So just to clarify, the Metro Boston Crisis Intervention training is a training program. So we're not a crisis response team. But what are some of the factors is, we talked about COVID for sure. I think that, there's a new system. The state had been recognizing that people were not able to access supports easily for mental health and healthcare in general. And so just this year in January, they launched the, kind of a new philosophy, a new program called Roadmaps to Help. This is a statewide program. And so, part of the challenges is where do you go for services? And so many programs have eligibility criteria. So it's not just, well, if you're, don't have a certain income or don't have housing, you don't automatically fit into all the housing programs, right? So there's these eligibility criteria that sometimes make it very difficult. One of the things that we do, the Homeless Coalition is another, a great program, and they work to get people into housing, but they would often have trouble. They require an assessment. Individuals need to have an assessment done to verify that they have a condition, right? In order to be eligible for something. And so they couldn't get a doctor or their, the person's provider to do that assessment, or maybe they hadn't seen their provider recently. So that's something that Jen's done a lot of. She's done a lot of assessments, via Zoom, in person. We try to be flexible, meet those needs. And I think just kind of with COVID has had so many ripple effects. We definitely saw folks, we are human beings. We need social connection. And it's been hard. And I think there's a lot of, subtle ways that COVID still continues to influence and impact us. And then in addition to that, there's a shortage of psychiatry. Insurance can be a barrier. So again, if someone has, Medicare or Medicaid, there's certain requirements on those insurances. So I've seen people not be able to get access because their insurance requires a specific licensure that a lot of the community agencies don't have. So that can be also a challenge. Transportation can be a challenge. So yeah, lack of supports. We're a global community, which it has its advantages, but so many of us don't have those local, kind of familial or peer supports. You're kind of in a new place, and that kind of disconnection can absolutely be an influence as well.
I was also just going to add that I think just stigma has been, a big challenge. Just part of our work here, because we're in the police department, there's a lot of people that, they might have more of a classical mental illness, or they're seeing therapists, they're open to addressing mental illness or mental health needs. But a lot of what we see and what we're dealing with is like life stress. People that either, there's so much going on, they've had a police encounter or not, but they're just dealing with stress, and coming here sometimes, meeting with us in the police department feels less potentially stigmatizing than going to see a therapist in the community, or acknowledging like I don't need a therapist. I mean, there's a lot of people we talk to, I don't need a therapist, but I'll talk to you. I'll talk to Cheryl, but I'm not going to go see a therapist. It feels almost, it normalizes it. We're recognizing how prevalent, real life stressors are. It doesn't have to be like a diagnosable mental illness. And often, they're coming to the police department because they want a police response. They think that people are following them. They think that they're being tracked, or and there's just distress in that as well. They're going to get the police response. Police are going to check it out to see if it's reality based or not, but they're still going to check it out, and we're going to help them with that distress. I feel like being here and being open kind of breaks down that barrier, that challenge of stigma for people that may or may not either have a classic mental illness, acknowledge that they have a mental illness, or want to, basically, it's like a lot of people with housing issues wouldn't be like, well, I have housing issues, I'm stressed, I'm going to go see a therapist. But here we are, and we're going to help them potentially look at housing, fill out applications, and then we're going to talk to them and see if we can, figure out what their needs are. So it kind of, subtly can reduce that stigma just based on meeting that need and normalizing it. Everyone's dealing with something. So how can we help that person?
Absolutely. We have a constituent question that says, how can people who don't feel safe in a police station access help? For example, people who are undocumented.
Yeah, that's a great question. I think that there's, kind of a lot of misconceptions about that. So anyone can call. We want everyone to feel comfortable reporting a crime that has been, offended to them. We want police departments are a resource. And so it's important to understand that when someone calls police, the police are not asking about documentation status. That has nothing to do with the call for service. And so, that never even comes up. So you should be very confident that you can walk into the station. They're not going to run your name and say, oh, or ask you, where are your papers? Where are your documentation? That will never happen. That happens after the fact. If someone is arrested for serious crimes, at that point, there will be considerations for that. But that's a court process. It's not a call for service for the police department. And in fact, it's kind of been, what I love about this work is that I am constantly learning so much. And we've had the honor to really accompany people through so many processes. We had a wave of helping people. I think we assisted like 6 or 7 people with their citizenship process. We have interns here, so it's a great learning experience for them. So, we'll help people apply for that and then study for the test. And it really is an eye opener for our interns. If you ever saw the questions on a citizen test, you'd be like, oh my God, I'd better study if I had to take that test, So again, just that awareness of, the challenges and the complications. So yeah, so again, people should feel very reassured that, their documentation status is never going to be a question on a call for service or when they walk into the department. And one of the things that we do, Denise, is, if people, because we are co-located here, if someone is, wants to come in and report something but is hesitant, we'll say, you know what, why don't you come on in? We'll meet you outside. We'll walk in with you. We'll, accompany you to the front desk. So we recognize that those concerns are real for people, and it's not so, oh, well, they said, no, that's not going to make you feel better, but know that our staff will kind of make those efforts to help you feel more comfortable. So we'll go out, we'll meet people outside. I say, just call me, let me know when you're here, or I'll look for you if someone's really nervous. Why don't you come by at 3? I'll stand outside, or one of us will stand outside. And we'll walk in together, right? So we recognize that those are real concerns. We don't want to minimize that experience, but the fact is that that will not be a consideration.
Thank you, Patty. I would like to add to that we are a sanctuary city. There's an official welcome ordinance, and so to that end, it supports everything that you just mentioned in regards to an undocumented person having access to the program. I also want to acknowledge how wonderful it is that you and your staff are very intentional in how you work with our constituents so compassionately, intently, and with so much awareness to what could be a different need from one person to the next.
Yeah.
We have a next question. Many community members have stated that they prefer that COHR not be housed within the police department. What are your thoughts on this?
Yeah, I understand, it's been something that we think about a lot. I think though, if we were to move outside of the police department, that we would lose a lot of the effectiveness and ability to connect with the folks, our population that we are connecting with. An example of that is, as you look at this, slide with all of the different community partners, I think about, oftentimes the Bay Cove or the Somerville Homeless Coalition, they're working with getting people housing. And as you know, it's kind of like the opportunity comes and you have to seize the moment. And so staff from the Homeless Coalition or Bay Cove will say, hey, we haven't seen so-and-so around lately. We're concerned because we started working with their doctor and, they're due for, kind of an assessment or something medically. Have you guys seen him? And so we have, the luxury of having a 24/7 partner here who is out in the community. And so we'll send out an email blast, hey, concerned about this individual. Has anybody seen them? Just recently, with housing, someone's name came up for housing, and that's a time sensitive. They don't call back. Oftentimes people may not have, phones, or their phone isn't charged. And so again, we were able to send out an email blast, and an officer's like, oh yeah, I know so-and-so. I know somebody who often works with them, and they were actually able to arrange for a ride to get them to the coalition to fill out the application. And so it's kind of, again, one of the most unique aspects of being here is, as we talked about, the officers are writing reports. So when we are following up on calls for service, it's initially just, hey, we're just following up. We're civilians. We don't have anything to do with the criminal justice side of things. We just really want to understand how you're doing and if there's anything that we can help you with, support you. And most people, like I described earlier, oh yeah, no, I'm good. But because we have the context of what people were experiencing in the moment, the officers' reports include who was there, what else was distressing. They were concerned because this is the third time their loved one had these issues or this behavior. This has been ongoing. They tried to do this and, they're kind of out in the middle of the night, whatever. That context allows us to use that and say, you know what, break down those barriers, because it's very intimate personal information that the officers are seeing people in their environments. And so we're able to just check in with people around, well, I understand that you're concerned about your loved one. Maybe they've had a number of overdoses, how did they do? I understand they went to, how are they do? Oh, and then that opens the door. So it really breaks down that barrier of people always feel isolated with those kind of things, like, oh my God, my family, we're the only ones. And unfortunately, that's farthest from the truth, right? And so again, that normalizing that these are nothing to be ashamed of, these are challenges, and there are supports out there. And so it really, so we would lose all that. We would really lose all that if we were here. And also, I like to break down the barriers. Whenever someone comes in, if they're comfortable, we often introduce them. There's maybe officers in the lobby, or, we make it there. Everyone's part of the community. Oh, Cheryl, have you met, Dave? He's an officer, right? And just want to say hello. That's it. No pressure, no obligation, but just so that they're a familiar face and that you had an opportunity. Unfortunately, most of us are only, in mine too, before I started working with the, I never imagined myself working for a police department. I am not a conformist. I would have never thought when I started my career that this would be the place that I would want to work. But because it's such a great, they're based in the community and they're seeing people in their environment, which, Jen says all the time, this is real social work, right? This is what it's all about, that biopsychosocial framework of what is influencing people's struggles. It's not like, oh, you have this weird illness, you're unusual. No, these are normal things, understandable given the stressors. And the police really are a connector. They know the community, they're out there, they get to know neighborhoods. They see, in addition to the inside, the home stressors, the external stressors. Maybe there's construction going on. Maybe there's, traffic or whatever, right? That can cause concerns. So that really helps inform and get us over a lot of those barriers and hurdles to talking about difficult topics.
Thank you, Patty. We do have another constituent question. However, before I ask that question, I just wanted to ask a point of clarification question. Do you also collaborate with the fire department?
We do, but not as much. So occasionally we will get calls or information from the fire. Sometimes we'll share information with fire about a constituent that maybe has some specific health needs if they should encounter them. But we're primarily working with the police department.
Okay,
We've done
thank you.
training with fire.
Oh, that's
on
good.
mental health.
Can I just add that I also, think that, meeting the clients where they're at, being here in the police department, when they come in, being accessible, not having to have them go to another building or get somewhere from point A to point B. We're here, they're coming for a reason, and we're able to help, like in real time, mostly, is like Patty said, like really true social work, really being a resource here, and ideally helping the community to see the police as the resource. They're open, like Patty said, 24/7. Having that be a place, and people do, they walk in off the street to look for detox sometimes, and we're there for that. So I think we're just really being here helps meet that need for those folks that are coming here.
Yeah.
I think
And
also,
if I could, I know there's oftentimes some concerns about, are we obligated? Are we obligated if someone shares something with us? Are we obligated to then, and it's maybe, not a legal matter, are we obligated to tell the police? And the answer is no. So we operate as a co-located system. And so when someone is talking to us, it's under a clinical, perspective. And so we are obligated and through our profession and our ethics to maintain confidentiality. The same exceptions apply, like if you were in a healthcare system. If someone is reporting that they're going to be at immediate harm of harming themselves or specifically intending to harm someone else, then yes, we are mandated reporters and we have to report those things. However, if someone comes in and they've shared with us they're using illicit drugs, or they've done something, shoplifted or whatever, we're not like saying, well, got to turn you over. Yeah. So it's really important to understand that there is confidentiality. We are kind of that co-located model where we're operating under our professional ethics and guidance. And when someone does have a criminal matter, we're involving, for the diversions, for example, we always have to divert to the officers. We think this person is a good candidate for diversion. Would you be on board? This is what we'd like to do. This is, what we've assessed the system to be. And, most times, officers are on board, and then we partner to go to the court. So the officer and the core unit and the individual go to the courts together to present that diversion plan. Yeah, so
Thank you
we're
for
not
that.
coercive either. I mean, people can come and go. They don't, we do ask, we're always asking, would you be open to signing a release? It helps us with care coordination. But if people don't want to do that, that's fine with us. So.
Sorry. The next constituent question we have is, in the scenario previously mentioned where an officer comes over for legal support for someone walking in, what happens if someone says something incriminating about themselves or others?
So typically the officer is there to answer a factual question, something about the process or what would happen if. And so it's highly unlikely, and informed consent, right? So, there are very few incidents, unless someone was saying that they were immediately going to go out and specifically do something that would cause, harm to the public. They're not going to necessarily, kind of implicate themselves. And if that's where they're at, then hopefully they will, and we can help them and others be safe. But mostly it's kind of, we manage it as an informational session. It could be sometimes, a lot of times people will be like, well, hypothetically, if this, so, we support people just as a way to gather information. So.
Thank you, Patty. We have a question for everyone. Are there any tools or programs that you might consider or desire to improve how you serve our constituency?
Yeah, I mean, I think, one of the things that we always say is we operate as a staff, as a team rather. And so, we're all pitching in. So when someone comes in, they might be primarily working with me or Cheryl, but if I'm not available or Cheryl's not available, there's someone else to kind of step in. I think, when I think about models, we've done a lot of focus on trauma-informed care. Trauma-informed care is much more than attending a training, right? It's really practicing and applying those concepts. And that's what we strive to do all the time. I think, our numbers have been increasing. We've talked about how complex they are. We definitely could benefit from additional staffing. At one point, we had a recovery coach. I'm a firm believer in peer supports. We would love to kind of get back, to having that level of staffing as well. Peer supports, recovery coaches. We've established a couple of things that we've done through our internship program. Is we had an outreach at the library, the West Branch Library. So an intern was staffed there, on Monday afternoons. And it was an absolute success. They connected with people. It's just kind of breaking down those barriers to talking about things and providing, kind of that information. We also have a residence, a private, a nonprofit housing development that, kind of had a number of incidents. So we ended up placing a staff there. So we're kind of, anything that we can do to be public facing. I'm a firm believer that we need to be out there in the community with people, as well as, be, kind of in a space that people can come to. So, I mean, there's Somerville's doing some great stuff around the engagement center at the Homeless Coalition, things like that. I don't know, Jen and Cheryl, if you have any other ideas of programs or services.
Well, I'd like to see a lot more for homeless people. I would like, I think the needs for people that come in looking for resources as far as alcohol and drug, that certainly needs to, we need to expand there. I work a lot with families of, and it's great that a lot of people will come in that have kids that substance abuse, has an SUD, substance abuse disorder, or alcohol disorder, and they'll come in and they'll ask for help in dealing with that. I wish that there were much more resources for that out there. And even if there are resources, you have to wait. Nothing happens immediately, which is I think where the core comes in. That we're great working with people until their doctor can get, they can get an appointment with their doctor or get into a detox or, whatever. We work, like I say, with Catholic Charities quite a bit, and they've been tremendous. We work with the Somerville Cambridge Elder Services, which they have a lot of clients that may come into the department or they may have issues with, and sometimes just meeting with those people in the spur of the moment helps. So I guess we're very good in spur of the moment, if that makes sense. We're here 5 days a week.
And I would say it would be valuable. I mean, as I said, we do rely on the officers, and I know there's a lot of conversation about policing and things like that, but we had been on a track with community policing, and unfortunately we've lost that unit. And community policing is an important a way to connect with community as well. A resource for us. We have like CIT coordinators, which is a very minimal part-time, role for the department, but it's useful because they get to hear from providers and constituents about what their challenges are, so that continues to inform police response. And so it'd be great to bring back, I think, community policing in a way as well.
Thank you. I want to give our constituents the last warning to please send in their questions as we're coming down to the close of our webinar. And while we wait for more questions from our constituents, I would like to give an opportunity for our core panelists to share a little bit about their individual roles. My RSJ department was blown away by everyone's bios, and so we think it's valuable for everyone to know just how wonderful and at expert level the staff at COHR are.
Thank you, Denise.
Thank you.
So I'll start off and we'll go around. I'm Patty, as you know, I'm the director. So my role, my background has always been in community social work. I've never worked in a formal clinic setting, and I think that, kind of has been a good background for developing this program. I've like believe it or not, yes, I started when I was 5. Now it's over 30 years of experience. It's true. Back in the day. Worked with primarily with adolescents and families at the start of my career, and then got more into working with the adult populations. I've always been interested in criminal justice to some extent. I worked at a residential program for offenders for a while. And my role here is I'm the director of the unit. So I manage the grants, supervise staff, do some of the budgeting, attend meetings for the community and other initiatives within the city. And then I also carry a caseload. Unfortunately, because of staffing, we rely on interns. They're only here for 8 months or so. And so, we plug them into overdose outreach. And then I typically am the person who will fill that because it's, kind of extended hours. We don't have the coverage to do those programs. And so that's a little bit about me. Cheryl?
Yeah. So I've been here in the department for almost 11 years. My office is right on the main floor when you come into the police department. And I've built a relationship with the officers and a lot of times the people that come in. So I do a little bit of everything. If that, I hope that's a good enough answer. I'll help anyone that walks in. I'll direct them to wherever they need to go. But when I first started, and even up until now, I'm a jail diversion coordinator. So like Patty said, we'll get a case and I will, Patty and I will read through it. And a lot of times, many times we'll ask the officer if they would be willing to possibly do a diversion with a certain client. And then that's where it starts. That's when we call in the client, we call in the officer, we'll talk about, hey, listen, something happened, it's life, things do happen. We're thinking of possibly a diversion. Are you willing to do this? So we then get in touch with the officer, the court, and that's how this whole thing begins. And I've had many clients that have done tremendous on the diversion, and it's worked out extremely well. So that's going back and forth with the client, maybe the client coming in, the client having to go to court. The process may last 6 months, it may last a year, where the client will check in with me. I get a report, are you seeing your doctor? Are you doing this? Are you doing that? Collaborate everything, pull everything together, and then let the court system know that they've been on probation for 6 months or 1 year on the diversion. They haven't gotten into any trouble. Where are we going to take it from here? So that's when the case, well, it works out extremely well. So I do the diversion, and a lot of times after the diversion, the client will ask to continue to come in, which is great. And that client may stay out of, or does stay out of trouble. So I've had many cases over the years that have worked out tremendously. I'm very happy to say. And I also work with a lot of times people with addiction issues will come in, will being in the field, you make the calls, you hook the person up, you get them a ride. There's a lot to it. It's just not calling and saying, hey, do you have a bed for this person? There's a lot that goes into it, and it's time consuming, but the person goes in, that works out great. And also my role is working with with the families of.
And then Jen, do you want to, I know we're running out of time. Jen, want to go next?
Sure. I've been here almost 4 years next month. Prior to being here, I worked at MCI Framingham Women's Prison for 12 years. I started as a social work intern and left as the mental health director, and was really just seeing people be sicker and sicker in the prison, physically, mentally ill, trying to do the best that I could and my staff could to help people to navigate and to be well and try to hopefully get out of the prison and continue to be well as best as possible. But was really looking to be like a little bit more proactive into the community. This is my first job in the community, and I will say that I thought the prison was chaotic, but it's definitely like a controlled chaos in the prison, and the community is there's just so much going on. It's like the Wild West. Like, I don't know where my clients are sleeping, what they're doing, what they're eating, who they're talking to. I knew so much in the prison. And so really trying to create those relationships and partnerships and utilize those connections to help people it's been a really interesting challenge. It's been really eye-opening for me, and doing the trainings with the officers. So I'm the co-director of the Metro Boston CIT TTAC training piece of it. So really just interacting with the police, hearing about what their sort of struggles might be, getting real life scenarios from them has been hugely helpful in my learning about community. And then my work with COHR, I have a caseload. I do other cold call outreach as well, has really informed my training with the officers. So it kind of works together where it's all informing each other and me. I also supervise interns from the social work schools. So just trying to, help people in the community, train officers on de-escalation, and recognizing how mental illness or just life stressors or whatever else is going on for people can inform a police response or can interact in a police response. And the best way is for the police to help that interaction resolve peacefully, has been my role.
All right, and quickly, Sabrina.
Hi, I'm Sabrina. And so I grew up in Somerville. My family migrated from Haiti and lived in Medford for a hot second. But then we moved to Somerville when I was like 5, went to kindergarten here all the way up through high school. And so I grew up with, they're retired now, but like the officers, I had a school resource officer at middle school and high school. And so it was really just cool when I started working at the department, some of the officers I went to high school with. So it's really just nice seeing that full circle. And we partner with the high school with the en route program. And so I have them come into the department and they get to speak with the officers as well. And when we had an SRO, they had like just a career conversation with the SROs, just getting to know their community members. And so in terms of COHR, I have a research background. After high school, I worked in a clinical psych program for a little while. And so here, just the opportunity to put numbers to the hard work that everybody does. I don't necessarily work directly with clients. And so adding just codes, just like the amount of unscheduled appointments that everyone has been able to accommodate, the amount of walk-ins, the referrals from the city, from the fire, from police, from Cataldo, and just really quantifying the partnerships, like even this slide to see, just give an idea of how many partners that we have and just counting them. And on the Metro Boston side, I also get to speak with departments in the area because there's a lot of just transient individuals, people coming in and out. And we know we share a lot of the same people, just struggling in life, but trying to figure it out. And so it's just about how do we communicate? How often are we seeing them? How often are you seeing them? How can we work together to address this person's needs and doing it in an intentional and systematic way so that if it comes up again, we're ready, we have that data, we have proof. And so it's been really awesome just being part of the team. And I still live in Somerville. And so just really knowing the resources and sharing it with my neighbors and with my parents, like, oh, go to Patty or like, there's a unit here. These are the hours. And so that's been awesome.
Thank you, everyone. I want to make sure everyone had an opportunity to share. Yes. All right. Well, this brings our Q&A period of this webinar to a close. This brings our webinar to a close. Thank you all for an informative session here this evening. To continue this conversation and learn more about public safety for all within the city of Somerville, please visit the RSJ Department's Public Safety for All micropage. We have placed the link on the slide and in the chat for your convenience. We have also, once again, placed the links to COHR in the chat as well, and Metro Boston CIT TTAC program. Our micropage for Public Safety for All is somervillema.gov/PSFA. In the coming weeks, we invite you to join us for additional sessions within the Public Safety for All informational series. And you can look forward to sessions that will inform you more about Public Safety 101 within the city of Somerville and our leadership that guides the public safety efforts, effective emergency response, public safety data in Somerville, and public safety response models and response models that are currently in place in other cities. Once again, a special thank you to Patty, Cheryl, Jen, and Sabrina for joining us this evening, and to all of our attendees for an informative and engaging conversation. We hope that you were able to learn more about COHR, their team, and the ways in which they work to make Somerville safer. If you would like to learn more about COHR, you can do so at somervillepd.com/divisions/COHR and at www.metrobostoncit.org/contact. We've also shared this in the chat, as I mentioned before. Please follow us on Facebook and Twitter, and stay tuned for more informational sessions. Thank you, everyone. Have a great night.